for the presentation, and thank you all for being here. These are my conflicts of interest. So this slide is just to remind you, if you have forgotten, that we saw many patients with acute respiratory failure during the last few years. This is the first paper that we had that we published in JAMA, but you can see there are more than 1,500 patients in few weeks, almost all of them intubated, so very severe patients. And so if the question is COVID-19 and ARDS, well, the answer, the very easy answer, is that patients with COVID-19 fulfill all the criteria of the Berlin definition, because they have acute respiratory failure, they have a known risk factor, and most of them, they have the criteria of hypoxemia with at least 5 centimeters of water of hip. So from the definition-wise, they have ARDS. But as you know very well, since the disease appeared, we had a lot of people claiming that COVID-19 is different from classical ARDS, you know, the theory of the two phenotypes. And so the idea, the debate started arguing whether COVID-19 pneumonia is or not ARDS. So I don't really know if this is an interesting question. I want to show you some pathophysiological considerations on the causes and mechanisms of hypoxemia in COVID-19 and what we have seen in our work. So this is the classical model of ARDS. Basically, what we think is that in classical ARDS, which I remind you is a syndrome caused by very different diseases, there is consolidation, alveolar collapse, shunt, and the level of hypoxemia is related to the amount of shunt, as Massimo told us. And the model of the baby lung is that the smaller the baby lung, the lower will be the compliance of the respiratory system, the higher is the shunt fraction. So this is the classical model of ARDS we are used to think of. COVID-19, especially in the early phases, is looked some way different, because we have all seen that in the early phases of COVID-19 we have seen a certain dissociation between the severity of hypoxemia and the amount of consolidations at the CT scan. So the easiest and the most probable interpretation of this is that in COVID-19 the main driver of hypoxemia are primary alterations of lung perfusion that lead to severe ventilation perfusion mismatch. So we all know that COVID-19 is a disease of the vascular tree of the lung. Is this unique to COVID-19? Well, I would not say so, because well, it's been demonstrated in COVID-19. This is a very popular paper, I think, from the New England Journal of Medicine that compared patients with COVID-19 and patients with H1N1 pneumonia, and basically showed that patients with COVID-19 had a much higher rate of vessel thrombosis, endothelial injury, and neoangiogenesis. So it's definitely a vascular disease of the lung. But again, is this unique to COVID-19? Well, again, I would not say so, because since the 70s, the group of Warren Zapol defined ARDS as a vascular disease of the lung. And Massimo showed a very similar picture as I'm doing. As you can see there, the vascular tree of the normal lung and the vascular tree of the ARDS lung. And they observed multiple pulmonary artery filling defects. And so they said that a distinctive feature of ARDS, of what we call classical ARDS, is pulmonary artery thrombosis. So also classical ARDS has an important vascular side in the generation of hypoxemia. So we said that the main determinant of hypoxemia in COVID-19 is VQ mismatch, and we have both sides of VQ mismatch. We have hyperperfusion of poorly ventilated lung units because of increased cardiac output and increased pulmonary shunts, loss of hypoxic vasoconstriction, anatomical changes, neoangiogenesis, for example, and this leads to areas of low VQ ratio, as Massimo showed. On the other side, we also have hyperventilation of poorly perfused regions because of vasoconstrictions, microvascular thrombosis, hyperinflation due to excessive PEEP level, and this is associated with the generation of high VQ ratio, which is that space. So we tried to assess some of these in this paper. Massimo already showed you this slide. This is a paper that we conducted with Massimo, Marco Ranieri, and a huge group of investigators in Italy on 300 patients with COVID-19. It was at the beginning of the pandemic, so these were all patients of from the first wave. They all underwent protective mechanical ventilation, volume control. That was the level of PEEP and the starting PF ratio. We measured compliance. We measured ventilatory ratio, which is a proxy of dead space. We measured the D-dimers as a proxy of the amount of vascular disease in the lung. We also took CT scan in a certain number of patients, and we compared COVID-19 patients with classical ARDS, and we took the controls from the Lung Safe database and the Berlin Definition database, and you know that we observed a slight difference in compliance, but not so huge, and while we observed the high levels of D-dimers, for example, and the high level of ventilatory ratio, and the distribution of compliance basically was this, so we did not see the two distinct phenotypes of compliance because compliance had a unimodal distribution, and these are the reconstruction of the CT scan, and you can see there that we were able to subdivide the patients in 4 groups according to the median level of D-dimers and of compliance. And in patients with high D-dimers, you see a lot of these purple areas, which are areas of hypoperfusion, and you can see here on the right-hand side of the slide the three-dimensional reconstruction of the pulmonary artery tree, and all the red spots are thrombotic appositions in the pulmonary arteries. So again, a diffuse vascular involvement that justifies the important VQ mismatch in these patients. We observed a huge difference in mortality for patients who had both low compliance and high D-dimers compared to the others. So patients who had a combined vascular and parenchymal insult. And to explore, to assess the distribution of ventilation and perfusion, we also conducted this study with Tommaso Mauri. The study was published in Critical Care Medicine, and it's again from patients of the first wave. It was done with EIT, and in this study we showed that there is a huge variability in respiratory mechanics, in recruitability of these lungs, and a huge VQ mismatch. You can see in the upper right-hand side the distribution of perfusion and of ventilation, and even for a non-expert, it's clear that they are not very well matched. Another intriguing point to compare COVID-19 and classical ARDS is the relationship between the severity of hypoxemia and the distribution of respiratory system compliance. So this slide is taken from our paper in Lancet Respiratory Medicine, and as you can see there, if you look at that slide, you can see that there seems to be a clear relationship in classical ARDS between the decrease in lung compliance and the increasing severity of hypoxemia, while this difference does not appear in COVID-19 patients. If I have to tell you, if I had to rewrite this paper now, I would not put this table in the paper, because here you compare only median values, and median values basically completely cancel the granularity of the data, because if you look more deeply into the data, you can see that even in classical ARDS, the relationship between compliance and severity of hypoxemia is very, very weak. This is taken from the secondary analysis of the Lung Safe study, while other papers in COVID-19 you see on the left-hand side of the slide a paper taken from a study conducted by Domenico Grieco and the group of Massimo Antonelli, and differently from us, they found a nice relationship in COVID-19 patients between compliance and hypoxemia. So again, there is a huge variability, inter-individual variability, both in COVID-19 and what we call classical ARDS. Last part of the presentation, this is a study that we conducted in our unit, and it's currently under revision. So we tried to study a little bit more deeply the pathophysiology of hypoxemia in COVID-19 and the response to different levels of PEEP and of the dead space. So we took 14 patients with COVID-19 ARDS with early ARDS from COVID-19. We performed the lung recruitment maneuvers, and then we did a decremental PEEP trial from 15 to 5. And at each PEEP level, we applied two different FiO2 levels, 100% and 40%. And at each step, we measured the dead space, shunt. All these patients had a pulmonary artery catheter and respiratory mechanics. And for some of them, we also took a CT scan. And these are the results. As expected, the shunt, intrapulmonary shunt fraction decreased from 5 centimeters of water to 10 centimeters of water of PEEP, and did not change from 10 to 15 centimeters of water. Not really unexpected. This is a little bit more surprising. This is the level of shunt at different PEEP levels at two different FiO2s, and you can see here that especially at 15 centimeters of water of PEEP, a little bit differently from what we expected, the shunt fraction tended to increase when we went from 40% to 100%, which is a little bit the opposite of what we would expect. And this is probably due to an effect on the loss of hypoxic vasoconstriction. It's not due to reabsorption atelectasis. And this is what happens to dead space. And again, here, as expected, this is dead space at 3 different PEEP levels at the same FiO2. And as you can see, the change in dead space is almost the same at the three levels of PEEP for the same FiO2, and dead space tends to increase at the higher PEEP levels due to hyperinflation of already ventilated lung areas. These are pictures taken from the CT scan. And again, you can see that there are different types of patients. There are patients who have a certain amount of recruitment when going from 5 to 45 centimeters of water, and others do not. And also, of course, in blue, you can see the change in hyperinflated lung units. So this is my last slide. Which summarizes a little bit what I think is that there are differences between COVID-19, which is a distinctive disease, and classical ARDS, which is a garden variety of different diseases. There are differences in pathophysiology, but we should not change our way of ventilating patients in the sense that we should ventilate patients according to their pathophysiological characteristics. So we should try to tailor our mechanical ventilation setting to that patient, no matter if he has COVID-19 or ARDS from pneumococcal pneumonia. Thank you very much for the attention.
Thank you very much, Giacomo. Any question from the audience? Yeah.
Thank you, Giacomo. Just a question. What is your position concerning the idea or the hypothesis of including in the definition of ARDS those patients who are still breathing high-flow oxygen therapy without any real PEEP? It's something that you see a possibility for the future, or is something that indeed is a wrong idea?
No, I mean, it's certainly something that we should consider, as we also wrote in the guidelines, because the use of high flow is becoming more and more popular, so it's very difficult to exclude those patients, though we have done a study together with you and Marco. We analyzed the patients with COVID-19 treated with high flow, and we tried to see across the course of their disease how many of them were then intubated and had non-invasive ventilation, and so in the end they fulfilled the criteria for ARDS. So, and I think that patients with bilateral opacities and severe hypoxemia on high flow, most of them, they will have ARDS if you apply a certain level of PEEP or an IV or invasive ventilation. There is certainly a small subset of patients who improve during high flow, and those patients have a completely different outcome compared to those who actually have ARDS when you demonstrate it, when you need to apply certain levels of PEEP. So I think that it's reasonable to include those patients, knowing that you will probably increase even more the variability of the patients you include in the trials, and so you have to accept that there is a subset of patients with a different outcome compared to all the others. But I think that for now, for the diffusion that high flow has, it's probably difficult to not to include them. I would be much more in favor to define as ARDS a patient with a certain level of PF ratio of a certain severity of hypoxemia after a period of stabilization, because in many trials we see patients who have the criteria for ARDS now, and after 24 hours they do not have ARDS anymore. That's probably something that we should take into account.
Any other question from the audience? Thank you very much for the lecture. I just have a question related to your last sentence, that you show clearly that the pathophysiology could be very different among what we call ARDS. So when you said should be ventilated in the same way,
yeah,
it doesn't contradict in the way that, what is the advantage of doing a recruiting maneuver, with the vascular occlusion is the main problem?
No, I agree. I mean, I showed that the pathophysiology can be different in the sense that the mechanisms of hypoxemia are always the same. Okay, shunt, dead space, VQ mismatch. In COVID-19, some of these are more prominent, but it's just because COVID-19 is a distinctive disease, and this is the first point. Second is that we have seen millions of ARDS all together in a very short period of time, and I'm sure that if you think of all the ARDSs you have seen, also with H1N1, some of them they had high compliance and low PF ratio. So my point is that we need to study, following a little bit what Massimo was saying, we need to study the physiology, the pathophysiology of the patient, and then once you have clarified the pathophysiology of the patient, then you should adjust your ventilation to that pathophysiology. So I agree with you, it's not rational to apply 20 centimeters of water of PEEP to a patient with 60 ml per centimeter of water of compliance. But this is not because he has COVID-19. It's just because it's not reasonable for the mechanical, for the pathophysiological characteristics of the lung.